This recorded session is dedicated to additional content or information about the streptococci and the staphylococci. I already covered a discussion on streptococci during our on-site lecture this week. And in the first part or the first recorded lecture for this module, I already discussed um, the major characteristics of staphylococci as well as the associated virulence determinants and the infection diseases that they cause. So let's breeze through this presentation and look at other key things that probably I wasn't able to discuss yet. Okay, so we already covered the um, morphological characteristics of the cells. Also, we discussed on these three phenotypes, the hemolytic properties, the serologic grouping based on Lancefield serology testing, the metabolic properties. So we already covered hemolysis. Okay, right. Then for Lancefield groupings, I already emphasized the groups that are clinically most important, groups A and B. The habitat, the um, expected reservoir and sources. As I emphasized during the on-site discussion that group A beta hemolytic streptococci do not really survive well outside the human body. Okay. All right, so this one probably I haven't mentioned that the infectious dosage or the inoculum volume or amount for group A beta hemolytic streptococci is very low. Even low inoculum can cause infection and disease. In terms of epidemiology, so it is transmissible via respiratory droplets and via skin contact, especially in cases of crowded environments. We already discussed about the virulence determinants, the capsule. I'm not sure if I mentioned that the capsule of streptococci is actually non-immunogenic. No? For the Fimbriae, I've talked about the M protein as an antiphagocytic component. Also, in relation to autoimmune sequelae. So the M protein can cause or is associated with um, the development of rheumatic fever as an autoimmune disease. Okay, protein F, I think I have not mentioned about this. So this is a glycoprotein that can mediate the attachment to fibronectin and usually associated with with cells that are in the pharyngeal epithelium, the bacterial cells that are trying to colonize pharyngeal epithelium. I also mentioned already about SPEs as an erythrogenic toxin. Okay, this one we talked about this. The cytolytic enzymes. Okay, yes. Streptokinase, streptodornases. Okay, this one, anti-C5a peptidase. So anti-C5a peptidase is another virulence, another virulence determinant of group A, Streptococcus, is actually it's a proteolytic enzyme. It's highly specific to CPA, which is a complement um, to C5A, which is a complement derived what do you call this? Chemotaxin. Okay, so the enzyme, the peptidase specific to it, inactivates C5A, and what it does is it prevents the recruitment of white blood cells on the area of infection. Then I also talked about hyaluronidase, mentioned this as an invasive property. Okay. All right, so this one, I'd like to discuss on the types of diseases in relation to, no, no, in relation to anatomical location. So we have streptococcal pharyngitis, characterized by the inflammation of the throat area. Uh, some parts that are included or may be infected include tonsils, the pharynx, the lymph nodes localized in the pharyngeal area. So this is the common streptococcal sore throat. Okay, so I've already discussed about this. Then for localized skin infections, we already covered folliculitis, cellulitis, impetigo, no? Fasciitis and erysipelas, we already covered last time. Okay. Scarlet fever, I discussed in our recorded lecture. Okay. Toxic shock syndrome, we associate with collapse of blood vessels, may result to cutting off of blood supply in certain areas, causing gangrene. Okay, so this one, autoimmune disease or autoimmune consequence triggered by infection with gas. We have rheumatic fever and post-streptococcal infections like the inflammation or the infection of glomerulus of filtering units of the kidney. So we have acute post-streptococcal glomerulonephritis. Um, so this one is actually on this section or at this juncture, I want to emphasize a few other examples of beta hemolytic group A streptococci that can, aside from pyogenes, so we have for the case of Streptococcus agalactiae, can be vaginally carried by 25% of women, can be a cause of neonatal meningitis as it occurs or as it exists in the vaginal tract of women, can be transmitted to neonates, can also cause pneumonia and sepsis. Then we have other groups of streptococci, the enterococci and the non-enterococci, which we classify under group D. Examples of these include faecalis and faecium. They're usually associated with nosocomial infections, infections that are derived from a healthcare setting, from a healthcare from we we also call nosocomial infections as hospital-acquired infections. Also associated with UTI, biliary tract infections, presence of bacteria in the blood, subacute bacterial endocarditis. Group D streptococci may also cause these kinds of diseases. So this is the appearance of Enterococcus faecalis under microscope. Okay. Then we also have the viridans group, the ones associated with the oral cavity. They don't really have a serological classification, no Lancefield antigenic classification. Some examples of these include S. intermedius and S. mutans. They can partially hemolyze blood cells. They produce green coloration in culture medium. So they are alpha hemolytic. So viridis, the term viridis means green. No? They can cause dental infections. If distributed in the body, they can also cause endocarditis and also affect the central nervous system, such as the brain. So there are abscesses that these group can also cause abscesses in brain tissue as well as in abdominal organs. Okay. Also in the liver, you can see abscesses caused by the viridans group. Then here for central nervous system, brain tissue, so viridans streptococci may result to abscesses in brain tissue. Then we have the pneumococci, so Streptococcus pneumoniae. It also has no Lancefield antigenic grouping. They appear as lancet-shaped diplococcus. They are obligate parasites of humans. They're found in the nasopharynx of healthy individuals. And in cases of an immunocompromised situation, they can cause infection and diseases. This you can see, Streptococcus pneumoniae. Appreciate the lancet-shaped appearance of the diplococci. So it's quite elongated compared to your Enterococcus or to your Streptococcus beta hemolytics. The major virulence factor of S. pneumoniae is the polysaccharide capsule, protecting it from potential phagocytosis. The capsule for this group is actually antigenic. And there are more than 85 capsular serotypes for pneumococci. Okay, so it can cause pneumonia and might cause infection in the ears, the inflammation of the medial area of the ear, otitis media caused by S. pneumoniae, characterized by secretions um, um, produced by the or secretory appearance of the ear portion. So there are secretions associated to the invasion of S. pneumoniae in the middle ear area. Other virulence factors include autolysin, which is a hydrolase, a peptidoglycan hydrolase, responsible for the release of intracellular virulence factors like pneumolysin. So autolysin allows for the opening of the cell membrane, opening of the cell, and the release of other virulence factors like pneumolysin. Pneumolysin is targeting mammalian cell membranes. It can bind to cell membrane of the host cell and can cause lysis of the cell membrane, and essentially lysis of the cell. Okay. Clinically, so we attribute S. pneumoniae to bacterial pneumonia and potential meningitis in adults. Already mentioned about otitis media, mostly in children, and can cause distribution of bacteria in the blood and potentially septic conditions. In the laboratory, so S. pneumoniae is showing or can be detected via tests such as the key lung reaction. Okay, so here you have what you do is a slide smearing technique where you put your putative S. pneumoniae culture, and then you add a small amount of the anti-serum, okay, and then your if there is positive identity, or if the inoculum is pneumoniae, then it will produce swelling of the capsule. So the key lung reaction will look like this. So the appearance will be like this. So the capsule swells, and you can see the diplococci in the middle of it. Then we have optokin susceptibility. So optokin susceptibility which it's a test, susceptibility test used to differentiate pneumoniae from other alpha hemolytic viridans. So it's specific for S. pneumoniae. So it can be used to identify S. pneumoniae from other alpha hemolytics such as the viridans streptococci, the oral cavity associated streptococci. Okay. Now, how do we prevent S. pneumoniae? It's highly preventable. So there's vaccine that can be used to prep the immune system of humans against it. No? Primarily advisable for the case of elderly, since old age is associated with more susceptibility or more higher risk of being infected by S. pneumoniae, and also by people, as advisable to people with without spleen. So those people where their spleen has been excised or removed already, so vaccine for S. pneumoniae is advisable. In terms of treatment, so there are particular antibiotics that can be used or can be prescribed. Penicillin, for one, for cell wall synthesis, to prevent cell wall synthesis, as well as ceftriaxone, and erythromycin, on the other hand, for protein synthesis, to inhibit protein synthesis of the bacterial pathogen. For Staphylococci, so I already talked about the morphological characteristics and its relatively resistant nature. No? I mentioned this already. Okay, yeah, protein A, we talked about this in the recorded lecture. Cytolytic exotoxins, I've talked about the hemolycins already. The superantigen exotoxins relating to toxic shock syndrome and poisoning, food poisoning. Oops. Toxic shock syndrome, so I've already talked about this. Yeah, okay. What else? The epidermolytic toxin, okay, causing SSS. Coagulases, leukocidins, penicillinase, yeah, they can, S. aureus can express penicillinase, therefore inactivating beta-lactamase antibiotics. Staphylococcus, similar to the mechanism of action of streptokinase. And I think I mentioned that S. aureus can also express lipases, allowing them to conquer fat-rich areas of the human body like sebaceous glands. In summary, so we have diseases due to exotoxin release can be related to the GIT, gastroenteritis, can be related to the overall generalized toxic shock syndrome, and SSS is also related to exotoxin release. Diseases due to direct organ invasion are as follows. So we have pneumonia, meningitis, osteomyelitis, acute bacterial endocarditis, septic or infective arthritis, bacteremia in the blood, and UTI. Already mentioned about osteomyelitis and septic arthritis. Okay, localized skin infections, almost similar with that caused by streptococcus. Okay, and then an important note, so there is a very a significant medically significant drug resistant strain of Staphylococcus aureus, methicillin resistant Staphylococcus aureus, which in hospital or healthcare settings, the tendency that is observed, or the trend that is observed, is SA can acquire a broad spectrum susceptibility to broad spectrum or to a spectrum of antibiotics. Okay, and as such, no, the development of multi-drug resistant strains. Because in the case of in the healthcare setting, the use of antibiotics can drive selection pressure. So others, particular or in summary, no, so when S. aureus is being treated in a healthcare setting, the application of antibiotics, which might be most of the case are broad spectrum, can select for specific cells or genotypes that can resist the effect of these broad spectrum antibiotics. And MRSA is one of those that are one strain that came about, no, that came out from this artificial selection process or event that is usually happening in healthcare or treatment contexts. Okay. So I'll be recording three more sessions.